I wanted to start by thanking Thai Red Cross and the organizers for allowing me to be here today. You will notice I'm possibly the only person on the agenda today who doesn't have an MD or a PhD after their name. I'm here to bring experience from the field. And I was asked to talk about promising key population innovations across the HIV cascade. So you'll maybe bear with me if this is a little bit of a whirlwind tour, because there's a lot to talk about and not all that much time. So I wanted to start just by making sure we're all on the same page. When I talk about key populations, I'm talking primarily about people who inject drugs, female sex workers, men who have sex with men, and transgender men and women. And these are the populations that in 2017 accounted for roughly 1/3, and if you take into account their sexual partners as well, accounted for about 1/2 of all new HIV infections globally. So globally, this is where infection is happening. These are also the populations that, because of a combination of their individual risk behaviors and their social vulnerabilities, are the most likely to become HIV infected. They're at much higher risk than members of the general sexually active adult population. But in country after country, these are also the populations that are least likely to have access to the prevention, testing, and treatment services that they need to either remain negative or get access to treatment to protect their health and the health of others if they become positive. That's where Linkages comes in. Linkages, for those of you who don't know, is a global PEPFAR-funded HIV prevention care and treatment project through USAID. It's being implemented by FHI 360, and it has the goal of improving performance across what we call the HIV cascade. And what I mean by the HIV cascade is that historically, when we looked at HIV interventions in the field, we tended to talk about either a prevention intervention or a testing program or a treatment program separately. The idea of the cascade is that these services do not exist in isolation. They're not separate interventions. They're part of a continuum. And the goal of Linkages, taking a cascade perspective, is not to look at one particular step along the cascade. It's to look at how do we bring people into this cascade, how do we move them across the different stages of the cascade, and how do we retain them over time. So that's what I mean when I talk about the cascade. And when you look at the cascade presented like this, it looks very clear and logical and simple. That's the theory. This is maybe more the reality. The HIV cascade as a series of old, rusty, leaking pipes where people are brought in at one end, but they leak out along the way. And so they're not retained in the system. And really, it's been the goal of the Linkages project around the world to do a couple of things. To first, better characterize and understand what the cascade looks like for different key populations, because different key populations move through this cascade differently. To understand where people are leaking out of the cascade and the reasons why. What are the challenges? What are the barriers? And then to come up with innovative models to, as I like to say, patch those leaks. To overcome the barriers so that people who are brought in the cascade remain in the cascade to the point where they have initiated treatment and are achieving viral load suppression. So that's what we're trying to do with Linkages. The primary approach for how we're trying to do that is what we sometimes call a differentiated services delivery approach. Now, I know there are a lot of doctors in the room, and you may be used to the concept of differentiated services delivery for HIV treatment. I know that's something that's being discussed a lot globally. When I talk about DSD approaches, I'm really talking about DSD approaches across the cascade for prevention, for testing, and for treatment. And when I say differentiated, what I mean by that, generally speaking, is we're looking at individual subpopulations and the socio-demographic characteristics of those subpopulations. We're looking at the characteristics of individual clients within those subpopulations and what they need and what challenges they face. And we're looking at the context in which we're interacting with them. Are we interacting with them in the community, in the field? Is it in a healthcare facility setting? Are we interacting with them virtually in an online space? So it's looking at all of those different factors and then providing a menu of options that we think will provide the best and largest possible set of choices for different members of key populations to access services. I just wanted to, very quickly to give you an idea of the type of scope we're talking about. I said Linkages is a global key population program. So at our height, we were working in 35 countries around the world. We're currently in 29 countries where we're either supporting direct service delivery or providing technical assistance, or a combination of both. And the advantage of this is we have currently 29 countries where we have an implementation science platform to figure out what works for different key populations in those contexts to bring them into the Cascade and keep them in the Cascade. But we also have global reach. So when we find innovations that do work, we can scale them relatively quickly for key populations around the world where we have individual programs who can help to adapt those innovations for their local context. And what I want to do for the rest of this talk is share a few of those innovative models that look like they have been at least preliminarily successful in many different countries around the world. And the way I want to do that is by following the Cascade. So I want to start briefly by talking about innovations that have helped us to reach the right KPs. And the primary innovation I want to talk about here is what Linkages calls an enhanced peer outreach approach, or EPOA, and what some of you, especially those of you with research backgrounds, might be more familiar with if I say this is a snowball sampling model, or this is a respondent-driven sampling model. This is an outreach methodology where, just like with traditional outreach, we have teams of trained workers who are in the field trying to identify members of key populations and provide education, give them condoms, refer them to services. But in addition, for each new client that we recruit into the program, we ask them to help recruit members of their social and sexual networks into the program for us. So essentially, we turn our program clients into recruiters that we call peer mobilizers, and we ask those people to expand our program reach by bringing new people into the program. The important facet of this model that I want to make sure people understand is this model is initially intended to cast a wide net, to help us bring large numbers of new people into the program, but it's not intended to stay that way. This is a model where over time, what we encourage countries to do is examine their data, drill down into their data, and look at, well, where are we being most successful at finding new HIV positive cases? And over time, adapt our recruitment protocols to focus on those population segments, on those social networks, and on those individuals, so that this model is really optimized not so much over time for high levels of coverage or even high levels of testing uptake. It's optimized for high case finding over time. And just to show you what that looks like, this is an example where EPOA was implemented among female sex workers in Côte d'Ivoire. This was over about a 2-year period, and you can see where EPOA was introduced. This was a program that historically had relatively high levels of testing uptake, but low levels of case finding among this target population. Where EPOA was introduced, the actual total number of people testing for HIV went down, but the case finding rate went up dramatically just over 1 quarter when this new model was introduced. In the next quarter, it was canceled. It was stopped, and they went back to sort of a traditional outreach model, and immediately the case finding rate went down. And their reaction was to then restart the EPOA model and continue this peer-driven recruitment approach. And when they did that, again, the 2 subsequent quarters, case finding went up again. And this is a pattern that we have tended to see in many countries around the world, where we use these peer mobilizers to bring members of their networks into testing. Testing yields go up. This is another example from Indonesia, and in Indonesia we actually have a comparison case where we look at PEPFAR-funded sites implementing EPOA and global fund sites who are implementing a more traditional outreach approach. And what we've seen in Indonesia is not only is EPOA generating more people being tested, it's generating consistently and significantly higher case finding. And this is, I think, yes, this was among MSM, but as I recall, we see similar patterns among other key populations, with one exception, which I'm going to show you. Because we took the Indonesia data and we broke it down more fully, and we looked at, under the EPOA model, we looked at clients who were recruited in sort of the first wave by our outreach workers. and then clients who were recruited by their peers in those subsequent waves of recruitment, and we did a comparison. And what we tended to see across key populations was while the clients recruited by outreach workers in the first wave were a much larger number, the testing yield among that smaller group of people recruited by clients themselves was significantly higher. So those peer mobilizers who were not trained members of the project were outperforming trained outreach workers in terms of finding the highest risk people and bringing them in for HIV testing. The only place where that pattern did not hold true was among female sex workers. And again, that's something we've tended to see across countries where female sex workers have appeared to be a little bit less willing to recruit members of their social and sexual networks into testing as compared to a traditional trained outreach worker-led recruitment approach. I want to shift to Thailand for just a moment, because in this slide, what you see over on the left-hand side here is a mapping of recruitment that happened by peer mobilizers in Thailand. And when we mapped recruitment here, what we found, to our surprise, was we had specific individuals who weren't just recruiting 5, 10, 12 new people into the program. They were recruiting 50 new people, 100 new people, 150 new people with relatively quite high testing yields. And we didn't understand how that was happening and who those people were. So we investigated, and what we found were the majority of the time, those what we called super recruiters were people who had large online followings on social media, on a website chat board. They were people who had access to large groups of our target populations virtually over the internet, and they were recruiting those people into the program. So what we have tried to do in Thailand is expand this peer-driven recruitment model to be a virtual online recruitment model as well. And you can see here, we recruited what we call social media influencers. We gave them individual online links to an online HIV testing website, and then we tracked over time to see how many people they were recruiting and sending to this reservations website to make a reservation for an HIV test, and what was the outcome of that test. And just to back up a little bit, this is over the course of about 3 years in Thailand. For MSM only, we looked at all of our different recruitment models. So traditional outreach, peer-driven outreach, clinic walk-in, and we looked at online recruitment. And we wanted to see how many people are being recruited, how many people are being tested, and what is our testing yield. And what we found across all of those was while online recruitment contributed a quite small proportion of our overall program reach, it recruited the highest risk individuals in terms of case finding. So in terms of recruitment efficiencies, online recruitment appeared to be quite an important strategy to follow up on. So we drilled down into this data more. Said, okay, well, online recruitment, what kind of online recruitment? And we looked at online outreach workers. We looked at those influencers that I just mentioned. We also looked at online advertising, so banner ads on cruising apps, or videos or posts on Facebook or YouTube. And we looked at the comparative contribution of those different recruitment models. And again, we saw that the influencers outperformed the online outreach workers quite significantly. What we did not expect was that the advertising far outperformed any other form of online recruitment in terms of both the number of people reached and brought in for testing, and also the case finding that was achieved. So it looks like this online, what I would call an asynchronous advertising model was quite efficient at reaching the type of people we needed to reach. And so we drilled into that a little bit more and said, what types of online advertisements? Is it online testing websites? Is it cruising applications? Is it social media like Facebook and YouTube? And again, this actually is not as much of a surprise to me, but case finding is coming from social media and cruising apps because that's where our target audience is. These online testing websites, that's where we try to bring our target audience to. But when we go to Facebook, when we go to YouTube or Grindr, we're going to where the target audience already is and finding them there. So it's not a surprise to me that we're finding relatively large numbers of people, but with high case finding. And looking just a little bit more in detail at that, we're able to drill down to what specific online platforms. So Facebook, YouTube, and Hornet, which is a cruising app for gay men and other men who have sex with men. And Hornet alone accounts for half of all of our case finding from all of our online recruitment methodologies. And this one platform has a 17% case finding rate among clients who are recruited on that platform. That's higher than any of our other models of online recruitment. So this is the reason I'm spending more time explaining this approach is because I think this is a clear example of how we've been able to use granular data to really drill down and look at what approaches, what platforms, what populations, what's working, where are we finding cases, so that we can adapt our approaches over time and achieve higher yield in our program. All right, but that's just the first half of the problem, is bringing more people into testing. I want to shift gears for a minute and talk about how do we make testing easier for people to get once we've recruited them. And one of our key models here that's being rolled out globally is HIV self-testing. I think we all basically know what we mean by self-testing. You collect the sample yourself, you perform the test, you interpret the result, and that can be done either wholly on your own, or it can be done under an assisted model where someone is giving you instruction and guiding you in how to do it. Self-testing can also be implemented under lots of different models. It can be outreach self-testing, it can be facility-based self-testing, it can be self-testing integrated into index testing, or self-testing through an online testing model. There are lots of different ways to do self-testing. When we introduced an assisted self-testing model under Linkages LAO, first what we saw was rates of HIV testing uptake increased dramatically and immediately. We also saw that we had initial increases in testing yield that declined over time. And when we drilled down into our data, we found that part of the reason for that was we were no longer recruiting the highest risk individuals into our program. So again, we shifted our recruitment strategy. We brought in more high-risk individuals, and subsequently our testing yield, since we changed our recruitment strategy, has increased quarter on quarter over time. But the other thing we found, and the thing that may speak to some of the healthcare providers in the room, is that it is possible with an HIV self-testing strategy to successfully link self-testers to facility-based confirmatory testing. I know this is one of the biggest concerns about testing, about self-testing, and we've shown that this can happen. When we introduced it originally in LAO, we had quite low rates of successful confirmatory testing among those who had a reactive self-test result. It was about 1 in 3. We considered that serious enough that we actually paused the program and went back and looked at our referral protocols and strengthened them to make sure we were not losing clients to follow up if they had an initial reactive testing result. And what we found is we've been quite successful with those revised and strengthened protocols. And over time, we've achieved almost 100% successful linkage to confirmatory testing. Now, we're also doing HIV self-testing in Thailand. I'm not going to show you all of the results, but one of the things that we learned in Thailand was how critical it was that we offered options. So in Thailand, we offered not just assisted self-testing, we also offered unassisted self-testing. And I was a bit surprised to find that by and large, assisted self-testing was more popular than unassisted. More people opted to have someone help them do a self-test than opted to do the self-test all by themselves, except when we recruited MSM via social media. Because when we recruited MSM via social media, the vast majority of them wanted an unassisted self-test. They did not want assistance. And when you think back to my earlier slide about how high risk the individuals that we're recruiting via social media platforms are, I think it's critical that we have service delivery options that will work for that subpopulation of our audience, because that's where we're finding positive cases. And we don't want to lose them because our testing models don't fit their needs or their preferences. I also want to talk very quickly about index testing. This is index testing is one of the global priorities for PEPFAR programs in 2019. Under the Linkages project, we are implementing sort of traditional index testing models, basically following a voluntary partner referral approach. But we're also implementing a second model that we call risk network referral. The key difference between VPR and risk network referral is that under risk network referral, we are not telling positive clients only recruit your sexual partners. We're telling positive clients, you're a member of a key population, you are HIV positive, please recruit people you know who you think would benefit from an HIV test, whether that person is your sexual partner or not. So we're starting from positive cases, positive index cases, but we're casting a wider net. Now first I want to show you, in Haiti, Haiti implemented a traditional voluntary partner referral model. 93 male partners from 40 female sex worker PLHIV with a 32% case finding rate under an index testing model. That was many times higher than the case finding rate in their traditional sort of outreach-based testing program. When it was implemented in India, we actually compared our EPOA model that I talked about before with an index testing model. Now the EPOA model had a 19% yield, which was significantly higher than the traditional testing model, which tended to have a yield of around 1% or less. So EPOA far outperformed traditional outreach in terms of finding new cases, but index testing outperformed EPOA. In terms of its testing yield. It did not reach as many people, but it had a much higher testing yield than the EPOA model. So it's sort of, again, becoming ever more granular and ever more focused on this issue of yield and efficiencies when we're recruiting clients. The one I really want to show you is LINKAGES Nepal, because in Nepal, they implemented a risk network referral model. They had 379 index cases. Those cases recruited 176 partners and children with a 36% testing yield, which again is much, much, much higher than just the typical outreach testing service. But in Nepal, they also asked index cases to recruit their friends, people that they were not having sex with, but they thought were high risk. They got an additional 29 clients who would have been missed under a traditional voluntary partner referral model, but the testing yield among those social contacts was 48%, even higher than the testing yield among their sexual partners. And the data from Nepal, again, to me, making the case for when you're dealing with key populations, casting a slightly wider net. And being able to capture more extremely high-risk people who might otherwise be left out of HIV testing programs. Okay, 8 minutes left. The last step in the cascade that I wanted to talk about is what do we do with individuals after they've tested positive? So much of our program is focused on achieving high yield, but what happens when we achieve that yield? And we have populations of newly diagnosed HIV-positive individuals who need to be put on treatment as quickly as possible. For linkages, the global model that we have been rolling out across our linkages countries has been a peer navigation model. By peer navigator, I mean usually members of KP communities themselves who are HIV positive, who have strong connections with our HIV treatment providers, and who work as part of a case management team. So peer navigators don't work in isolation, they work in collaboration with a nurse, a doctor, a counselor, a social service provider. So they're one part of a team, but they have responsibilities for working with PLHIV, providing education on treatment, helping them to navigate treatment facilities, accompanying them when they have hospital visits and reminding them when they have upcoming checkups. And in some places, taking it a step further and even providing clinical services like conducting regular home-based clinical care follow-up visits. And in some countries, even being able to distribute ARVs in the community to clients who are stable on treatment and might not need a visit to a healthcare facility. So this is our sort of global peer navigation model, and it's often integrated into a differentiated ART service delivery approach where we're not requiring all ART to be delivered at healthcare facilities. ART could be available at a public or private sector healthcare facility. It also could be available through a community-based drop-in center or some other form of community-based ART distribution. So the idea here is choice. The idea here is figuring out what individual clients need, and with a diversified model where some clients can be served in the community, reducing the burden on public sector healthcare facilities so that they can focus their time, resources, and attention on the clients who actually need more intensive medical care and follow-up because they're less stable on ART. Again, this is more data from Indonesia, where peer navigation was introduced early in the program and has had a significant impact over time on increasing the rates of successful enrollment in treatment. Here in Nepal, peer navigation was introduced as part of a series of innovations for ART treatment uptake, which started with the introduction of community-based workers to mobilize clients for testing and treatment, and then added on the addition of a nationwide test and treat policy to increase access to ARTs, and then ended with the introduction of a cadre of trained peer navigators to help follow up with those individuals who had been lost in the gap between diagnosis and treatment. And as these innovations rolled out, you can see the very clear increase in successful linkage to treatment that happened over time in that program. I wanted to make the point that peer navigation and differentiated service delivery is not just about treatment initiation. It can also be about treatment retention. Here in Haiti, they introduced a nationwide, what they called a peer navigation surge, where they hired and trained a large number of new peer navigators, gave them performance-based incentives and transportation fees to bring people back onto treatment who had been lost to follow-up. So these were clients who had already initiated ART and disappeared, and you can see the impact of introducing peer navigators in terms of immediate increases in numbers of lost to follow-up clients who were brought back onto treatment. And not just brought back onto treatment, but brought back into viral load monitoring as well. So when peer navigation program services were introduced, coverage of regular viral load monitoring went up dramatically over the course of one fiscal year. So peer navigation for treatment initiation, but also for treatment retention and adherence. I'm actually not going to talk about this because I have 3 minutes left, and there was a speaker this morning who already talked in detail about the same-day ART model that's been piloted by Thai Red Cross here in Thailand. The only point I want to make about same-day ART was that we have shown that that model can be successful among key populations at not just bringing many more people into treatment, but keeping them in treatment over time, even when they have to be transferred to a new treatment provider, and achieving over 90% levels of viral load suppression among people who started ART under a same-day or rapid ART model. But the last sort of approach I wanted to talk about, and I just wanted to tip my hat to this because I've been talking about the prevention, testing, and treatment cascade, but PrEP is sort of a new piece of this cascade. It's the piece of the cascade for clients who are tested negative. And what do we do with those clients? And so I wanted to very quickly share the example from the USAID Health Markets Project in Vietnam of a community-based, community-led PrEP model where KP-led organizations are providing HIV testing and generating demand for PrEP, are doing risk screening and referral to PrEP services, and are partnering with clinics to do laboratory assessments to provide PrEP and to provide community-based follow-up care to make sure that clients are retained once they initiated PrEP. And you can see, as this model has been introduced under Healthy Markets in Vietnam, you can see the increase in PrEP users among the MSM population in Vietnam, but critically, you can also see the high rate of retention on PrEP under this model, this 75% retention rate. Retention on PrEP is a global challenge, and Vietnam appears to be one of the countries that is cracking this challenge, and they're doing it at least in part through a model that is partnership between clinical service providers and community-based organizations. Which leads me to my final points in my remaining minute of time. What we have found in linkages around the world is that when we look at Cascade improvements, there's no one-size-fits-all solution. There's no model that is going to work for every target population everywhere. Services need to be fit to the context and the needs of the target population, so they need to be client-centered. They have to be data-driven. They have to be analyzing their data to see what works and adaptively changing their programs over time, and they need to offer options. When they offer options, community partners can play a key role, not just at prevention and recruitment, but across the cascade, can play a key role in expanding the options for service delivery, and that increasingly, as we've seen with online interventions, clients are capable of reaching themselves when we make the resources available to them. So what's our next step? One last slide. Our next step is making sure that as we roll these models out, they're sustainable over time. And sustainable means these models and this menu of options needs to be locally owned, and it needs to be supported with domestic financing. And this is where I want to share, this is brand new data from Thailand, where we have spent the last several years working on harmonizing government and NGO systems so that community-based organizations can receive and monitor domestic financing. And we have worked to build co-created accreditation and quality assurance systems so that where governments are financing these services, they have confidence that the services are being provided of high quality and according to agreed upon national standards. The result of this work in Thailand is that in 2016, the Thai government provided about $160,000 in funding for community-based organizations. In 2018, that number has increased to $1.3 million in financing, and we hope to see that increase continue over time as we can demonstrate to the Thai government the critical role these key population organizations play in delivering services to highest risk individuals so that the country can achieve their 90-90-90 targets. I wanted to end by thanking the many people who provided information and experiences and slides for this presentation, and of course our donors and LINKAGES global partner organizations. Thank you.
Thanks, Matthew. That was really exciting. Do we have anybody who has any questions for Matthew?
Hi, Matt. I know you told me not to ask questions. Thank you very much for that presentation. And I'm really curious. I mean, as you see from the index testing, we have really high yield, and the majority of the MSM in Thailand use cruising app as a way to seek partners. But in those applications, there's not really an option for you to actually exchange the contact information. And most of the time, people communicate within that application. So how would you make that connection? How do we actually get people from using the cruising application and actually linking and connecting them to come and receive HIV testing, because we don't exchange line or number. Thanks.
Yeah. So I think that's an insightful and crucial question. Our index testing models need to be fit to the ways in which members of community key populations network and communicate with each other. We are currently here in Thailand working in a model for online risk network referral where an index client can have essentially a link to a testing reservation platform that they can send themselves to any of their contacts over whatever platform they wish. So for instance, if they have their cell phone number, they can send them a link through the cell phone. If they are in contact with them on, for instance, Grindr or Hornet, they can use the communications, the chat functions on Grindr or Hornet to send that link as well. So it can be used across any platform to link a partner or a friend to testing services. But what I'm really excited about is that we are in the middle of communication with Hornet, which, as I showed you, is where we're finding the majority of our cases online. We're in communications with Hornet about how we can integrate our online testing reservation service directly into the Hornet app itself. So that anyone who's a user of Hornet can access local testing services and maybe even one day order a self-test kit online without ever even having to leave the cruising app that they're using to communicate with their partners. So I think the real answer to the question, how do we integrate these services for online clients, is that we need to build relationships and we need to work with the platforms themselves. And of all of the online platforms, Hornet has far and away been the most open to building those types of partnerships with public health programs and public health agencies. So I think there's a lot of scope for future innovation there.
Great. Thank you very much, Matthew.
Thank you.